What do you have to tell us?
After this superheroic activities by sir, I will be presenting very basics.
Have you started?
Is the video playing?
I hope you will be showing only videos.
Yeah, just videos, 5-minute videos. VLC है ना? Yeah. Okay, so we do injection, anti-VEGF injection first before going for a vitrectomy. So especially hardest are the patients with combined retinal detachment. So this one's one of fairly simple case. He had a cataract also. So we went for a cataract surgery along with the anti-VEGF injection in the first sitting. And we do injection 3 to 5 days prior to a surgery. So after 1 week, we went for a 4-port vitrectomy. So we always use a chandelier illumination because it helps to do a self-indentation. Most important is the posterior hyaloid in patients with PDR. So we have to make sure that we remove the entirety of the posterior hyaloid. Then we check the periphery and do a vitreous base shaving. And finally, a pan-retinal photocoagulation. And depending on whether there's a break or not, we decide to go for a oil or a gas injection. So patient did fairly well, one-eyed patient. Again, patients with fractional retinal detachments, we have to do a 360-degree vitreorexis all around initially. Again, it's not possible in every case, but in cases where there is a subhyaloid bleed, there tends to be some amount of gap between the posterior hyaloid and the retina. So in those cases, it's easier to delineate the plane. Again, we have to break down delamination and segmentation. So we try to remove the entirety of the proliferation, but first divide it into smaller parts, find out the plane, and then go for a complete removal. Finding the plane in between the retina is the most important thing. We can do with the smaller cutter these days, but sometimes we might have to take the use of a bent needle. So this provides a very simple way to delineate the plane. Once we are sure we have picked up the posterior hyaloid, then we can go ahead and do the rest of the case. Whenever there is an increase in hemorrhage, we go for a increased intraocular pressure, we increase the pressure, and we can also use cautery or even laser is helpful. Again, finally, we have to do a pan-retinal photocoagulation, and depending on the case to case, we go for an oil injection or a gas injection. So some of the things is we have to be ready for a taut ILM. So in those cases, whenever we find a taut ILM, we go for a ILM peel as well. So these are, in fact, ILM peeling also leads to reduced diabetic macular edema in post-op cases, although I do not go for a ILM peel in every case. When I encounter a taut ILM, only then I do ILM peel. Otherwise, I leave it as such. Of course, there are schools of thought where in every case of PDR, ILM peel is recommended by some surgeons. Again, pan-retinal photocoagulation followed by a fluid air exchange. Most difficult ones are these combined detachments where it's extremely tough to delineate the plane. So triamcinolone acetonide is helpful, and whenever we find that there is some amount of PVD, we will try to create or increase it as much as possible in the regions where it is available, and the rest of the regions we have to go for a repeated attempts at lifting of the posterior hyaloid. Again, using a ILM peeling forceps at the disc, we can lift up the posterior hyaloid at the disc, and then we can go from center to periphery. These cases, we do end up with some iatrogenic breaks, and we have to make sure that we do a marking of the iatrogenic break using the cautery. And once that is done, we have to do a thorough laser in these patients. We can also use a bimanual approach in these patients, use a forceps to lift up the membrane, and then using the cutter to remove it and to do a delamination. Again, breaks sometimes do happen, and we just have to make sure that there is no fibrovascular proliferation at the disc, and go for a laser followed by oil injection. So with better equipment and better technology at our hands now, all diabetic patients, we can hope to attain at least some amount of vision in most of the cases. Thank you.
Thank you, Himadri, for your wonderful videos. In fact, the key to all this diabetic vitrectomy is that you should release all the traction before you end up the case. Otherwise, you end up with the recurrence. So that's why the ILM peel, everything becomes important at that stage.